It's a great Friday, everyone. It's so nice to see all of you. And you're still with me, Mela Habijan, your Miss Trans Global 2020. And welcome to the day two of You Matter, inspiring a client centered HIV response in the Philippines and Southeast Asia. And this is brought to us by International Aid Society Educational Fund and Love Yourself Incorporated of the Philippines. Today, we will be talking about you being able to live a healthier life with treatment and you leveraging on self-testing innovations, all of which will form part of our efforts in ending AIDS by 2030. Yesterday, our first two sessions focused on upscaling PrEP and PEP interventions and understanding unity against HIV. And to continue our session yesterday, here are our sessions for today. Session 3 will be about you live healthier with treatment, and session 4, you leverage on HIV testing. So now, to formally open the You Matter Inspiring a Client Centered HIV Response in the Philippines and Southeast Asia Symposium Session 3, please welcome Love Yourself Incorporated's Director of Operation and Research, Danvic Rosadino, for his welcoming remarks and laying down the agenda and meeting expectations. Danvic?
Thank you so much, Mela, and a good day to everyone. Our session 3, this symposium aims to discuss the main challenges and recent updates on the HIV response in Southeast Asia. And on the 2 days of our symposium, four main topics will be covered, of course, during our symposium. Of course, that's the PrEP and PEP interventions, stigma around HIV, PrEP and U equals U, testing and treatment as prevention in Southeast Asia, and self-testing and sharing of best practices from the region. Today, during our session, we will be focusing on testing and treatment, especially on how can we leverage the interventions, and also how can we promote U equals U in our region. Before we start our session, here are some housekeeping rules. All participants are currently muted, but you can ask your question in the questions and comments box right under this window. I invite you all now to please introduce yourselves by typing in the chat or interactive box that is right underneath the screen, and you will see that your message shows in the interactive box to the right of the screen. Please type in your first name, last name, the organization you work for, and the country you are from. Please use this opportunity to connect and get to know each other. Please send questions through during our speakers' presentations so that we can address anything that you would like to ask during our Q&A parts of the session. We are also pleased to announce that if you participate in our feedback survey, at the end of this meeting, you can request for a free 1-year International AIDS Society membership. All meeting participants will receive an email about this at the very last session of the symposium. Now, we will launch some introductory polls for you to participate in, and let us know, how are you feeling today? You will see some poll box in your screens now, and let us know, kamusta po kayong lahat? How do you feel today? Okay, let's see what the results are. Okay, let's just wait for a bit. Let's see. Okay, let's see what the results are. Oh, 55% great and 25% excited. But I'm also excited for all the learnings that we will be gathering during our last two sessions. And I hope you enjoy your day today. So thank you so much, and over to you, Mela.
Thank you very much, Danvic. That's a great number. 55% great and 25% excited. All because I guess, Danvic, you've given them your most beautiful smile and your warmest welcome to all of our participants. Well, You Matter Symposium again is possible because of all of you. With your attendance right now, we do hope and pray that your attendance to this symposium will be able to cultivate more and more practices that can help us build a free AIDS world by 2030. And before we start the ball rolling, let me just remind everyone that you can use the comment box to ask your questions or post your comments about the topic. And I'd be more than happy to read all of them for our speakers. We hope to answer them during our Q&A portion later. And to start with our discussions, let me now introduce you our first speaker who will update us on the latest developments on HIV testing and treatment. Please show some love to Mr. Wong Chen Song, Deputy Director of National HIV Program, National Center for Infectious Diseases from Singapore.
Hello, everyone. My name is Dr. Wong Chen Seong, and I'm the Deputy Director of the National HIV Program at the National Center for Infectious Diseases in Singapore, where I also head the HIV clinical program. I'm a consultant infectious diseases physician, and I would like to thank the organizers for their kind invitation to present to you updates on testing and treatment in the region as far as HIV is concerned. Now, the UNAIDS 1990 targets are what we follow in the region as well, and we really want to get at 1990 to try to reach those breakpoints in order to realistically bring about an end to HIV in the region and internationally by the year 2030. Now we know that in all likelihoods, we are a little bit off that mark, but still those targets are really helpful and useful for us so that we are all speaking the same language and trying to achieve this ambitious goal. And I think, and I firmly believe that it's actually eminently achievable. Now, as of 2020, and I got these data from avert.org, we can see that 75% of people in the Asian region as a whole, the Asia Pacific region as a whole, are aware of the diagnosis. But that's still 15% off the mark. And 1/4 of people living with HIV in the region are still unaware of that diagnosis. And that's really something that we in this region, in the Asia Pacific and in Southeast Asia specifically, could afford to really focus our energies on. Now, what about what it means for the true gap to reaching the 90s? I think there are still about 880,000 people who are out there who are not diagnosed. And this is that gap that we have to really try to bridge before we can say that we have reached that first 90. And it's something I think that policymakers, that practitioners, that community-based workers could really should be thinking about making steps towards achieving so that we can reach these goals. Now, late presentation, which is a function, which is a natural consequence of perhaps not testing and getting people who are undiagnosed, still remains an important problem in the Asia Pacific and in Southeast Asia. So, we already said that only about 3/4 of people living in the region are aware of their diagnosis, although they are truly infected. In Singapore, at least, closer to home where I practice, more than half of all people who are diagnosed are still diagnosed at a late stage in infection, where their CD4 counts are less than 200 or where they present for the first time with an opportunistic infection or other AIDS-defining illness. This is despite the fact that overall numbers of newly diagnosed patients are actually declining over time. But what we're still not really getting to the crux of is those people who are diagnosed, who are infected rather, but who do not get tested regularly, do not get tested early, and get tested really as a consequence of medical care because they present with signs and symptoms suggestive of HIV infection or advanced immunosuppression. Testing access and reach also varies fairly widely from country to country in the region. It's really, really excellent in places like Thailand and Malaysia, 94%, 86%. And this is really data that is available on UNAIDS, and it's really data that's reported. So it could well be that there are discrepancies. So the data that I presented here in Singapore is kind of, lagging behind Cambodia, behind Malaysia, behind Thailand, like I said. But we don't really have clear idea of what's happening in other places in Southeast Asia and other places in the Asia Pacific. And one can only hope that as more data comes in and as more efforts go into trying to boost early testing, that these numbers become more optimistic, more cheerful as time goes by. And what we want to see as well is that one of the UN AIDS targets is really looking at innovative means or interventions, testing measures that are more likely to bring about early testing to diagnose previously undiagnosed pockets in the community. So community-based testing, for example, and self-testing are two testing innovations that really could help reach these hard to reach populations and cohorts. And unfortunately, I've put arrows where countries in Southeast Asia are not many of our countries. Some of them do. Thailand and the Philippines, for example, have community-based testing and self-testing available. It's not yet available in my country, in Singapore, especially self-testing, although that's something that we're actively working towards. So I feel that the way forward for the region is really building on these UN AIDS identified and IAS identified interventions, right? Community-based testing, key population-led testing, providing services where they are most needed and provided by members of the communities themselves, where there's already perhaps some relationships built, some trust that's been built up, and some familiarity that may reduce the barriers to testing that often are present when you only have testing in healthcare facilities, for example. Self-testing is really the other vanguard, right? So reducing it helps reduce barriers to testing, especially amongst us who are hard to reach. It overcomes the stigma of HIV testing that's still widely prevalent in this region by allowing tests to be done in private, more confidential. And also, I think the third thing that we can't forget, and I think someone else is talking about in this series of talks, the destigmatization of HIV testing as a whole, and of course of HIV as a whole. Now, HIV treatment is the other thing that I'm talking about. And I think it's important to remember that in this region, in Southeast Asia and Asia Pacific, the general ethos and the goals of HIV treatment are universal. They're no different here than any other region in the world. And these principles are to start treatment as soon as diagnosis is made. So waste no time regardless of CD4 count. The goals of treatment are to achieve durable and stable HIV viral load suppression to reduce mortality, morbidity, and the personal health of the HIV-infected individual, but also to achieve an undetectable HIV viral load as soon as possible to reduce transmission, and something that we've gotten very familiar with, this whole principle of undetectable equals to untransmittable, something I think some of my friends and colleagues are already talking about in this series of talks. Now, the principles of treatment are also universal, right? The linkage to care, entry into the cascade of care, the care continuum as soon as diagnosis is made, initiation of antiretroviral therapy as soon as possible, if not on the same day that the person is linked to care and sees a healthcare provider, then at least rapid within 14 days, for example. Retention of care remains to be of utmost importance, making sure that not only do people start seeing a doctor or a provider, but they stay engaged in care and that they continue to take their medications and that all the systems are in place to make it easy for them to do so. And of course, the use of a regimen that is highly potent, that is as non-toxic, as easy to take as possible, as convenient to take as possible, and that it's provided in a way that is as person-centered as possible. Now, the World Health Organization, the IAS treatment recommendations, and in fact, most recommendations have moved away from older non-nucleoside reverse transcriptase inhibitor or protease inhibitor-based regimens to really recommend integrase strand transferase inhibitor regimens as first line, especially dolutegravir-based regimens for adults as well as for children. And dolutegravir and non-nucleoside reverse transcriptase inhibitors have also started to be recommended as second-line regimens in people who are failing a non-dolutegravir based regimen as a first line. They are potent, they lead to a rapid viral suppression and immune recovery. They have a good safety profile with really few drug interactions, a high genetic barrier to resistance, and are more forgiving in nature. Now, I did try to look and see what the treatment recommendations were in the region. I wasn't able to get them before I gave this talk, and I'll be really glad to have some discussion at the end of this to see which of the countries in our region are able to access it. Of course, cost is an issue with integrase transferase inhibitors in many of our countries, and I think that really should be a focal point for us to try to get costs down, whether it's through the use of licensed generics or just having trade partnerships to try to bring the cost of integrase inhibitor-based regimens down. And I think also the latest WHO recommendations in treatment monitoring and treatment switching really focus on a shift away from older NNRTI-based regimens and really looking at shifting to alternative and appropriate regimens that are more potent, that are less toxic if these start to fail. And I think it's a little bit of a culture shock. I know it was in Singapore a couple of years ago when we changed our recommendations, because NNRTI-based regimens have been, and in many cases are still, workhorses in the Southeast Asian region as part of our first line and in fact second line treatment regimens. So I hope I've sort of rounded up. Testing and treatment is such a broad topic, but I hope I've sort of distilled it down to what I feel are the salient points that we should focus on in this discussion. And I'll be happy to take any questions. Thank you very much.
Hello? There you go. I guess this is what live means, that we will be facing technical difficulties, but always grace under pressure. So once again, thank you so much, Wong, for sharing your experiences there in Singapore on how you address the HIV epidemic. But Wong, please do stay for a while as I now open the session for questions and answer. Again, if you have questions for our speakers, feel free to write them on our chat session. So Wong, first and foremost, mabuhay from the Philippines. How are you?
I'm good. How are you? Thanks for having me.
I am all good. I am so excited to be hearing you today, and thank you so much for gracing our event with your presence. So now on to our first question. I am very much curious with the situation there in Singapore. Of course, the cases of HIV and AIDS will always carry a stigma. How do Singaporeans face such experience of stigma in terms of HIV?
Thanks for that question. I think it's a great question. And, you know, I was listening to some of the talks yesterday as well. And I think one of the common themes running through many of the speakers who come from all over Southeast Asia is that HIV stigma is really a part of, you know, sadly, it's really a part of life and still kind of a part of life everywhere, including in Singapore. So I work, I work closely with people living with HIV, both clinically as well as, in the clinic as well as in research. And I think a common theme that has come about is that stigma pervades through every step of the HIV care cascade, right? It kind of it's a barrier towards people getting tested because, you know, the fear of being seen getting an HIV test is so much, or the fear of being diagnosed with HIV is so much that it prevents them from getting tested, and that's one of the reasons why many people present late, which is something that I talked about in my talk. There is a great stigma towards getting HIV care as well, and one of the unique situations in Singapore is that many of our patients actually, after being diagnosed, choose not to seek care locally, and in fact fly to neighboring countries like Thailand, other places like Hong Kong, for example, or Australia, or even go to Malaysia to get treatment just because they don't want to be seen in an HIV care center. And of course, this does have certain challenges and has become a real problem during the period of COVID when travel became very, very difficult. And I think the last thing that comes to mind is that unfortunately, many of our patients still feel a sense of stigma and discrimination coming from healthcare workers in Singapore, and that's something that the National HIV Program for which I'm Deputy Director is working really hard to try to address, all the way from sort of medical and nursing education to all the way to postgraduate training, really incorporating stigma reduction into the way that we teach people about HIV.
Thank you so much for those information, Wong. That being said, I guess as an advocate of HIV/AIDS there in Singapore, you still remain hopeful. What makes you hopeful that the stigma in your country per se will be addressed in the coming years?
I think the main thing that gives me a lot of hope is that it seems to be getting better almost with every generation. I remember when I was a student, a medical student, there was really nothing much taught about the stigma aspect, or you know, the social behavioral or the cultural aspects of HIV. Whereas now I've been practicing for a few years now, and I have medical and nursing students coming to ask me about how they can do better for their patients, for their constituents. I see that in the community-based organizations that I work with, the people who are passionate, the people who really want to make life and things better for people living with HIV, both in their generations as well as the generations to come, are getting younger and younger. And they, you know, I can't imagine being you know, I don't remember being like that even when I was younger. So I think it's all steps pointing towards the right direction. All the work that's been done by the people who've come before us has had some effect, has taken root. And you know, we, all of us, I think, stand on the shoulders of giants, and hopefully you know, things will get better, and that's what really gives me hope, you know, every day going into work.
Well, it will get better with people like you just really amplifying what it means like to live in a world without stigma, in a world that just really hopes for the best in terms of dealing with health crises such as HIV/AIDS. I think, yes, I agree with you. We are heading to the right direction. Now, from stigma, let's talk about solving late diagnosis. How do you think we can address this problem when clients are already experiencing AIDS-related complications?
Yeah, so I think the problem with late diagnosis will differ from setting to setting, right? It depends on what the local epidemic is like. So in my experience in Singapore, for example, many of the people who present late tend to be men who are older and who tend to be heterosexual men, usually male clients of female sex workers, for example. Um, of course, there is a small population of men who have sex with men who also present late, although generally speaking, you know, gay, bisexual, and other men who have sex with men in Singapore tend to be more likely to test voluntarily, test regularly and frequently, and hence be picked up earlier on in the stage of infection. The problem with late presentation could be very different in other places of the world. For example, if you have a setting where there are very strict drug laws, for example, and you know, it becomes very difficult for people who inject drugs to seek testing because of the legal repercussions, then you are going to face a problem where by the time they fall sick and present, that will be the first time they ever have a HIV test, which will be very late down the line. So I think the main issue is to, or the main way in which we get to try to solve this problem is to understand what the specific issues are behind late presentation in that setting. So in Singapore, we know that, you know, we have to focus our intentions on making sure that older heterosexual men have a higher degree of health literacy, have a higher degree of information and awareness around HIV, which is something that through, you know, studies that we have done, we know is greatly lacking. Perhaps it's about reaching out and getting testing more accessible, right? So we are hoping to introduce self-testing in the very near future. Perhaps what we need to do is to tell general practitioners and primary care doctors that when you have an older man who comes in and you have to ask them, have you had a HIV test recently? Would you like to have one done? So normalizing the conversation around HIV testing, making such that it's not only a test you get when you go to a sexual health clinic, but really any kind of healthcare facility should be able to be comfortable offering tests. And then you widen your net, and hopefully you get more people tested and linked to care as early as possible. So this is just a specific solution for a specific problem. So, you know, in order to solve it in your own setting, you need to understand, okay, who are those people who are coming in late and how can we best serve them?
Thank you very much for that perspective, Wong. It's so beautiful to be hearing that for us to be able to solve a particular problem, we need to know of its nature. And the nature is actually very specific to a particular place. So there is no particular way in addressing the problem, but rather there will always be a variety of solutions to a problem because we all have different contexts. Thank you once again, Wong. We have so many things that we've learned from you today, and for sure, we are about to learn so much from the rest of our speakers, whom we have this You Matter Symposium. That's why I'd like to reiterate to everyone, especially Filipino participants, that this symposium entails continuing professional development units but under the self-directed CPD accreditation scheme. Once you've all attended 4 sessions, we will give you instructions on how to claim your CPD unit accreditation. After this 2-day event, official communications will be sent to your email. And again, you have to complete all 4 sessions to claim your CPD units. Now, moving on to our next speaker. We are very lucky to have a speaker today. Unfortunately, our supposed speaker, Mr. Bharat Rewari of WHO Southeast Asia, won't be around due to an unforeseen situation. However, joining us today is the director of iTech India. Let's all welcome Mr. Anwar Parvez Syed.
Yeah, thank you very much, and good morning and good afternoon, everyone. I feel fortunate to be here today and listening to all the presentations. So, in a brief time, what we have, we'll be talking about treatment as prevention in Southeast Asia region. Okay, so in this brief time, we'll be talking about the overview of the region, Southeast Asia, and the concept of U is equal to U has already been discussed. So we'll try to again brush it on and also try to explain about the experience from Southeast Asia about this concept and what are we doing currently and the way we want to move ahead. So if we talk about the epidemic in the region and also especially in the Southeast Asia, so HIV/AIDS continues to be a major public health problem in the region, and but as compared to the sub-Saharan Africa, the percentage prevalence is pretty low, which is 0.3%, and in comparison with sub-Saharan Africa, which is 4.1%. But out of total 3.8 million estimated numbers in the 4 countries, 99% of which are in these 4 countries of Southeast Asia region, which are India, Indonesia, Thailand, and Myanmar. Slightly over 2 million were on ART, and about 170 million were new infections in the year 2010. On the right side, if you can look at the graph, 63% of the total cases of the region are coming from India, and rest of the countries share 17, 13, and 6% each. When we talk about the global targets of UNAIDS and achievement of those targets, the region is lagging behind in achieving the new a reduction of the new infections, which were estimated or they targeted to be 75%. But 24% targets have been achieved. There is still a gap of 51%. If we compare that with the global scenario, 19% targets were achieved and there was a gap of 56%. Comparatively, the region is fine, but overall, if we see there is a still lag of 51% of target achievement, and this is as compared to the numbers of our estimations of 2010. The key populations and their sexual partners are most affected by the epidemic. So they constitute to the extent of 98% of the new infections in the Asia and the Pacific region. And if we compare that with the global scenario, it is just 62%. So this continues to be a major section of the population. And when it comes to prevention, it is again the combination prevention practices are being followed in the region where treat all is one of the prime prevention strategy, in addition to the other strategies like regular testing of HIV and STIs, post-exposure and pre-exposure prophylaxis, prevention of mother-to-child or parent-to-child transmission that we call it here, and other harm reduction strategies, including treatment of STIs and condom promotion and condom usage. So when it comes to U is equal to U, the treatment as prevention refers to the HIV prevention tool, as the ART is used to reduce the risk of transmission, and it has been proved and demonstrated beyond doubt now. And 4 key studies for that are like HPTN 052, partner and opposite attract, and partner 2 trials. Or these studies have demonstrated the effectiveness of this strategy beyond doubt. that ART is being used for preventing sexual transmission of HIV to their negative partners. And this has led to the concept of U is equal to U, and this has become a movement now, whereas 872 organizations from 98 countries have already adopted this strategy. And the evidence behind U is equal to U, which I just mentioned in the four studies, says that as per the HPTN 052, there were no linked infections were observed when HIV infected individuals was stably suppressed in index and participants for more than 10,000 per person years. And also partner studies, zero link transmissions were observed in over 1,200 eligible couple where this was given. Similarly, opposite attract studies has shown the no or zero linked HIV transmissions, and also the partner 2 study, zero link transmissions in 77,000 condomless sex act as per among the gay couples. So the evidence is very prominent, and it is always has been proved now beyond doubt that it has been really effective strategy across. So WHO standpoint is really clear. So it says that the science related to the use of ART as an additional prevention tool is very clear. There is no evidence that individuals who have successfully achieved and maintained viral suppression through ART transmit the virus sexually to their HIV negative partners. There was a joint statement which was issued by the Ministry of Public Health of Thailand, along with the WHO, World Health Organization, and Joint United Nations Program on 21st February 2020, which says that U is equal to U means that the people living with HIV who achieve and maintain an undetectable viral load, they cannot transmit HIV sexually. So now coming to the countries, the four major countries in the region who have adopted these, the way they have adopted these strategies. So the key activities in Indonesia has been led by, again, Anne Rento. So he has done a fabulous work. And almost all these countries, the civil society organizations and NGOs have basically adopted this strategy, and they are doing whatever they can. So if, for example, in Indonesia, we can see U is equal to U, IEC material, and also use of Instagram to promote this strategy overall. And also, I urge you to go through their YouTube link for more information of these activities in Indonesia. Similarly, in Nepal, if we see all these IEC material has been developed in the local language for better understanding of the community by the USAID, PEPFAR, and EPIC project in Nepal. Again, there is a link below where you can go and look for all these beautiful IEC material under and for promotion of this particular strategy. And when it comes to Myanmar, again, WHO country office in Myanmar has launched the social media campaign on U is equal to U with support of PEPFAR last year. And also this was used in local languages, and which was really effective. And also I think it can be seen globally through this website. And finally, I'm sorry if there is delay in changing the slides. When it comes to Thailand, I think Nitya P, she is also there in this call, so from IHRI. So they also have done all this promotion activities for U is equal to U. And finally, when it comes to India, the VHS, Voluntary Health Services Organization, they launched a campaign of U is equal to U, and where they feature the local film actress in their promotions of the strategy, which was well covered by the leading Indian media. So lot was has already been done, and lot is yet to happen. So so many resource material is already available and ready to use. If you want more resources, now here are some on the CDC website, which can be easily accessed by anyone. So a lot of material can be found for its promotion. And just to keep it brief, and I'm just about to I think ahead of like a minute or so. So I'm sorry for that, and I acknowledge all the people who helped me or Dr. Revari in making this presentation. And I want to end just with this quote that use equal to you offers us an unprecedented opportunity to stop HIV transmission, but its impact is yet not fully utilized by all the countries. So thank you very much.
Thank you very much, Anwar. No need to apologize. We've learned so many things from you, from your passion and informative discussion of treatment as prevention, especially here in the Asia and the Pacific. And I know at this point, our participants want to have an academic chit chat with you. So they typed in their questions, and here are some of those that you can answer and shed some clarifications on. First question: for those who are undetectable, are all modes of transmission covered on the undetectable equals untransmittable concept?
I'm sorry, there was some disturbance. Can you please repeat?
This is one. The question is for those who are undetectable. Are all modes of transmission covered on the undetectable equals untransmittable concept?
Yeah, so the data, first of all, there's a disclaimer that I'm now talking on my behalf. I'll take all these questions to Dr. Revari also for his comment, who will be getting back to all of you later this day. But as we have seen, all this evidence which has come on U is equal to U is for sexual transmissions. So it may not cover the all modes of transmission as such, but sexual transmissions, for sure it covers, yes.
And having said that, in your opinion, how can we help communities to promote the messaging of U equals U?
Yeah, it's really, I think, great to have undetectable viral load. Its messaging is, I guess, really a key here. Understand first comes first. First is the information about the whole concept. First, putting patients on ART, and as the previous speaker mentioned, the late presentations of the people to the healthcare facilities and late initiation of antiretroviral therapies. So those are the things which we need to focus. And when they see benefits of ART and in an HIV positive who is already on ART, and after that, and in terms of showing the benefits, one of the ways is to show there with the numbers of the viral load. So initially, when they started, they might have higher viral load, and when it becomes undetectable, so they need to believe in this viral load routine monitoring. So which is sometimes which becomes challenging in some of the regions. And then you can talk about that if there is no viral load visible, so all these, there are so many evidences which are there in place to prove beyond doubt now that HIV won't transmit if the viral load is undetectable. But the key for that is to get the viral load done routinely and regularly. And also, I think as healthcare professionals, we need to go slow on people who don't want to accept it. So you need to give them messages, and it can be a process of transformation. Once you start giving that message, people may come up with so many questions. And I think it's really important for people to give clear messages to the community and explain the whole thing, and just not stop at one-liners, which may create confusions sometime. So it's really, I think, beneficial for everyone to explain the complete picture, and whenever it is required, we can talk about evidences. Otherwise, people can see the beneficial effects of ART. And if we can link that with the zero transmissions in undetectable positives, that will be, I think, great, and it will have a long way to go. Thank you.
I like how you highlighted education, and a very important ingredient of education is actually patience. You don't stop by just giving in a simple message, but you continuously evolve these messages because there is a constant need of explaining the situation, and we are constantly evolving as well. On to our next question. do we have an international, intercontinental promotions of equals U equals U?
If I understood the question correctly, it is now a global concept, and everywhere the evidence is similar for everyone. So I think everywhere it can be promoted. I guess it's clear for all of us that message is to believe in that for sexual transmissions, if you have undetectable viral load, there is a risk of zero transmissions.
Thank you very much for that. And now, on to our last question. I asked Wong about this, and now I'm interested into getting to your perspective. How do you think can we solve late diagnosis, especially when clients are already experiencing AIDS-related complications?
Yeah, thank you for that question. Completely agree with Dr. Wong before, and as he said, the situation is improving, and that's a good news. That we are now getting patients, especially after the launch of Treat All everywhere, which happened sooner or later at different regions. Unfortunately, there is still a section of society which is still coming to, there are still a group of patients which are coming to the health facilities late in the presentation. To deal with that, I think we need to promote the benefits of ART, especially the new form of ART or the new regimens which have come up, example, dolutegravir-based regimens. So there is a need to promote the beneficial effects of these regimens to the larger section, where people should be aware of its beneficial effects, and also at all, and especially targeting the key population clients. As in my presentation, I spoke about the major drivers of the epidemic in the region are key population and their partners. So their participation is great so far, and it continues to be great. But the treatment literacy has to be up to the mark in all key population groups, I guess, which includes the literacy about the newer regimens, not in great technical details, but at least the beneficial effects. And people should not be having questions in their mind when it comes to ART initiation. So countries have successfully rolled out Treat All so far, and for initiation of ART early in the the phase of the illness, I think it is a key to have early diagnosis, for which the easy protocols need to be in place, and which are to be made accessible, for which we can use different or differentiated service delivery models to take prevention and testing protocols also near to the key population if they are not able to access those services in the typical facilities which are available in the major public health setups. So I think we need to become more client-centric and work very closely with the key population so that there is enough awareness and there are no doubts in people's mind regarding ART. And when the time comes, if someone is diagnosed with HIV, it then becomes really easy to initiate the treatment, and that I think will solve the major problem of late presentation to some extent, I guess.
Again, that is making messages client-centric, promoting ARV, and promoting literacy, as it is really extending the benefits more than the technical aspects of how to address HIV. Thank you so much, Anwar, for your insights this afternoon. We really learned a lot from you. Thank you for gracing us with your presence. And
Thank you
before
so much.
the next part of our session, we will just have a 5-minute bio break, and we will come back with the next segment, which is about the same day antiretroviral therapy, or ART, the initiation and the concept of undetectable equals untransmittable, U equals U. We'll be back. And we are back. You are still at the second day of You Matter Symposium. I am Mela Habijan, your host for this afternoon, and this is session 3 with the theme You Live Healthier with Treatment. I hope so far you are learning so many things from our 2 speakers a while ago, and now we are on to our next speaker. I'm so happy to be seeing her again as she will be discussing so many things about what they have done so far in Thailand. So say sawadee ka to the director of the Institute of HIV Research and Innovation in Thailand. Let's all welcome Dr. Nitaya Hanupa.
Thank you very much for having me in this virtual symposium co-hosted by the IAS Educational Fund and Love Yourself. It is my great pleasure to share my thoughts around same-day ART initiation and U equals U with all of you today. I'd like to start by emphasizing that to change the paradigm of implementing an HIV program, we need to look at this through the status neutral approach lens, which equalized HIV prevention and HIV treatment. For individuals coming in for HIV testing, those who tested HIV positive will need to offer ART immediately to bring them to the goal of having zero risk of sexual transmission, while those who tested HIV negative will also need to offer PrEP immediately in order to bring them to the goal of having negligible risk of acquiring HIV. And over the past 4 to 5 years, ART initiation has been made much more feasible through the simplification, which is to reduce the complexity of the steps, as well as through differentiation to identify those who the service can be made light and those who the service must need to be intense. And then through demedicalization, which is to shift some tasks from doctors and nurses to other providers. And in Thailand, same-day ART initiation has been implemented since 2017 in Bangkok, and then subsequently expanded to 6 other provinces. And this year, we have included same-day ART initiation in our national guidelines, recommending that anyone diagnosed with HIV should have ART initiation within the same day of having HIV diagnosis or on the same day of hospital visit if HIV testing is not conducted within the hospital. And in many key strategic provinces, the community-based organizations or CBO who runs HIV testing clinics work really very closely with the hospitals who run ART clinics. And they both establish a fast track service where a client diagnosed at the CBO can be seen by the doctor at the hospital within the same day. And the history taking and physical examination as well as chest x-ray are the only key steps prior to ART initiation in order to rule out tuberculosis and cryptococcal meningitis. Blood draw for CD4 count and other baseline safety labs can be done, but results can be coming back a few days later. But ART will be initiated on that day. Follow-up visit is scheduled 2 to 4 weeks after that, just to check for side effects and to help with the transfer to longer-term ART facilities if needed according to the health insurance schemes. And in Bangkok, we can see that around 90% of those who were offered same-day ART initiation accepted it, and more than 80% had ART initiation within that same day of HIV diagnosis, and almost all of the rest had ART initiation within that week of HIV diagnosis. But in non-Bangkok sites, you can see here that almost 2/3 accepted ART initiation on the same day when offered. And here, still around 15% of ART initiation occurred after the first week of HIV diagnosis. So the main difference here, the key main difference is that in Bangkok, both CBO staff and healthcare providers who initiate ART use U equals U message as the key motivation to give to individuals who then consider the start and the stay on ART. And this table summarizes basic knowledge around U equals U from partner 1, partner 2, and opposites attract study. And basically, it shows that there is there's zero linked transmission among almost 130,000 condomless sex acts when HIV positive partners in these trials had undetectable viral load. And the similar level of confidence is seen in U equals U among gay couples as for heterosexual couples. couples. And U equals U is true even when STI were detected in a quarter or almost 1/3 of gay couples in the partner to an opposite attract study. And lastly, that more than 1/3 of gay couples reported condomless sex with other partners outside of the main relationship, pointing to the immediate need for PrEP for these couples. However, with this knowledge, obviously there are still concerns among healthcare providers in around U equals U implementation. And the first concern is that because now we cannot just simply use HIV transmission risk as a reason why we need 100% condom use, healthcare providers may now feel frustrated having to think about new techniques of how to empower their clients to be able to decide when condom is needed to prevent STIs, to prevent pregnancy. And the second concern is around healthcare providers who may not be able to trust their clients that clients can continue to take ART with good adherence. But here, knowing about U equals U actually is the best motivation for someone to want to maintain the best adherence to ART. And these two concerns are very important because it points to the implicit stigma that the healthcare provider may have, this unconscious stigma towards people living with HIV, being someone who is irresponsible in sex and irresponsible in taking medicine, which need to be realized and need to be addressed by healthcare providers themselves. Now let's talk a bit about communicating U equals U message, because language really matters and there is no need to modify the zero risk language into something like close to zero. And language also usually reflects attitudes, and no one should modify the zero risk language just because of their own moral judgments towards someone's sexual life. And lastly, U equals U is beyond condomless sex, and U equals U is about people living with HIV being non-infectious and about reducing stigma against PL-HIV and reducing self-stigma. So educating, communicating, and implementing U equals U is not easy, and Thailand is no exception. The success of U equals U in enhancing same-day ART initiation is only true among our small network, but the outside world is still very cruel to the level that a doctor wanting to advocate around U equals U can be harshly bullied by many other doctors who still want to talk about 100% condom use always. So what we can do now that we know that U equals U message may be new to many people and they may need time to digest, to understand and to trust the message, is that we can include U equals U in our guidelines, which will help dictate clinical practice. And then we can help incorporate U equals U into clinical education for all HIV service providers. And we may also want to create a concrete tools to help facilitate patient-provider conversations about U equals U to avoid selective language based on moral judgments. And we have to continue to broaden public awareness around U equals U. And by doing all this, it will greatly help enhance same-day ART initiation and also enhance ART retention everywhere. Thank you very much.
Hapun ka, Dr. Nitaya. I truly admire the work that you've done so far for PLHIV community. Same-day ART initiation spells a difference on loss to follow-up clients and a key to PLHIV's fast attainment of an undetectable status. So, Dr. Nitaya, I'm so happy to see you again. And during your presentation, our participants have sent in their questions through our comment box. And if you can further clarify these concerns, I will now be asking you some questions. First question, how do you convince governments to update their guidelines about same-day ART?
Thank you very much, and it's very nice to see you again, Mela, in this symposium. And that's a very important question in getting anything into guidelines. It's not always easy, and at least in Thailand, getting the intervention or practice into the guidelines actually is the very important step in leading not only to implementation but also to the reimbursement or to financing of that implementation or that intervention. And that's why we having same-day ART initiation being included in our guidelines is a crucial step here. And I have to say that it's not only that we can use science from elsewhere to convince people in certain countries or even like local setting, like in a province, to just follow the science that has been proved elsewhere. We need data, and the most important data for policymakers to look at is the feasibility and acceptability data, and that's why the data that we use to introduce the ART initiation into our guidelines is mainly the implementation data from Bangkok. And Bangkok only is not enough because Bangkok is not Thailand. So we also need this feasibility, acceptability data from hospitals outside of Bangkok and in key strategic provinces in Thailand to demonstrate that it's feasible everywhere. It's not just only in big city or in specialized clinic, but it's also in any provincial hospital or even a district hospital, which is smaller than a provincial hospital. And with those feasibility data, acceptability data, as well as advocates, who are doctors in the hospital, who are clients in that province, actually lead to the successful inclusion of same-day ART initiation recommendation into our guidelines. And that actually has led to our National Health Security Office, which is the one who pay for the service in the country, to also consider the incentive reimbursement mechanism in a way that for those providers who can initiate ART on the same day or on the first day of client coming into the hospital, you may get a higher level of reimbursement for your service cost, because it demonstrates that you put more effort, you put more resources into thinking of how this could be happen in reality.
Thank you very much for that, for those insights, Dr. Nitaya. What I've gained from you so far is that in order to address and in order to convince our governments, we need to present them data-driven and scientific research-based facts. And thank you for highlighting that the data must be gotten from across the country, because Bangkok is in Thailand. Therefore, we need a representation that is coming from across the country. And I guess this is what strengthened your desire into pursuing the promotion of the same-day ART as you're promoting right now. In relation to your answer, here's another question, a follow-up from one of our participants. And our participant asked, what are the precautions when the viral load is low? Is it still the same with people who have high viral load?
If this is, if I interpret this question correctly, it's about the potential for someone to transmit HIV to other related to the level of the viral load. And when we talk about viral load here, I would like to mention it a bit more, that we are talking about plasma viral load, which is the viral load level, the level of virus in your blood, which determine the possibility of that individual to transmit HIV to other people. And when we talk about U equals U, we are talking about the undetectable level of virus in the blood. and the untransmissibility of the virus to other people via sexual transmission. So I think to make it clear, when we talk about U equals U, we are talking about undetectable virus in blood and untransmissibility sexually to other people. And yes, when it's certainly true that for people with high viral load, then you have higher chance to transmit HIV to other people. And with low viral load, the undetectability level that we are talking here, if you look at those studies, the partner 1, partner 2, and opposites attract study, the viral load level that we use to call it undetectable here is the viral load of less than 200 copies per mil. So this means that in clinical practice, we usually will aim for the viral load to be less than 50, less than 40 copies per mil for your own clinical benefit. But if you have viral load less than 200, that's already good for you to not being transmissible to other people already. So you are not infectious already with that level of viral load. Some people are very much concerned about the frequency, the interval in between viral load, each viral load being measured, and I think that is quite ambiguous to say, because if you are talking about U equals U, and you also add in this unnecessary requirement for the frequent viral load monitoring, it means that U equals U cannot be implemented in many settings where you don't have resources to check viral load that frequent, you know. So I see and I feel and I fear that a few countries are trying to say that, okay, the world is talking about U equals U. Our country is also doing U equals U, but we need viral load to be measured every 3 months, every 6 months, which is not what the studies, the three main studies are doing. We are just measuring viral load according to what has been practicing in certain countries. So it could be every 6 months, it could be every 12 months. The most important thing is adherence, right? People, the client, they know themselves whether or not they will have detectable or undetectable viral load. There is no reason that a person will get to the detectable viral load if they continue their treatment with the best adherence. So I'm also would like to add here that we should, when we say undetectable, we should not base that only on the availability of viral load measurement. Otherwise, it will interfere the scaling up of U equals U implementation.
Thank you for highlighting adherence and consistency, Dr. Nitaya. Now, on to our next question. I guess we are learning so much that a lot of participants are asking so many questions right now. Dr. Nitaya, how do you obviate iris in same-day initiation of ART in Bangkok and other places in Thailand? Kindly enlighten. Dr. Rayesh Gopal, AIDS Control, Government of Gujarat, India.
That's a very nice question. And yes, certainly we are very much concerned about iris. And that's why when we say that we are only doing physical exam and doing chest x-ray, it is the steps, the key steps that we are trying to do to avoid serious iris, which is related to tuberculosis, especially tuberculosis in the brain, which can getting worse if you start ART prior to starting the treatment for tuberculosis, same thing to cryptococcal meningitis. So anything in your brain, it can risk you getting worse symptoms after starting ART or starting ART too early. So that these are only two iris that we are concerned, and that we think that by taking history and doing physical examination, it can reduce and also for us in this region to screen out tuberculosis by symptom screening, physical exam and chest x-ray. It will help us in reducing the chance of having this serious iris after ART initiation. So it means that here we may have to like screen out 5% of people, of those 100% people who were diagnosed with HIV, that 95% can start ART on that day because they don't have any history, any symptoms, any abnormal physical examinations, any abnormal chest x-ray to point to the chance that they may have tuberculosis, they may have cryptococcal meningitis, and they can start ART immediately. But for the other 5% of people, then yes, we still need to do further investigation. But it means that here we are doing differentiated ART initiation in a way that the majority of people can start ART right away and safely. And we can now pay more attention, use more time to take care of people who really need more time to do further investigation, but not for everybody. The other 95%, they don't need us to spend too much time on them before they can start ART.
Thank you so much, Dr. Nitaya, and of course to Dr. Rayesh Gopal who asked that question. But for the benefit of those who have just encountered the term iris, Dr. Nitaya, would you mind just shedding light on the concept of immune reconstitution inflammatory syndrome?
Yes, certainly. Iris Mela, you were wonderful. Immune reconstitution inflammatory syndrome. Yes, that is when the body has some infections inside, which means that you have a certain amount of antigen or that cause that illness. For example, for tuberculosis, we're talking about like a high burden of tuberculosis inside your body. And that usually when you have a very low CD4 count or high HIV viral load in your body, and then you start ART. And when you start ART, the immune system can come up or reconstitute very quickly to the level that it's just the amount of immune system, but not the quality of the immune system that can in turn harm your body by getting this huge reaction to the antigen that cause tuberculosis and cause inflammation instead of trying to get rid of the antigen and control the disease. And that's when tuberculosis in the brain may result in such a large amount of inflammation in the brain and cause the damage to the brain. And that's why we want to treat tuberculosis first to reduce the antigen in the brain, let's say, so that the immune system that comes back after ART will not cause too much inflammation, unnecessary inflammation inside the brain.
Thank you so much for that clarification, Dr. Nitaya. You really know what? I'm so happy to have you as a friend because I keep on learning from you. Besides, I sounded like I know of Iris, but thanks to our friends from Love Yourself here in the Philippines, I actually knew of the acronym, but I don't know what really it is up until already explained what Iris is all about. Now, on to our next question. This is our second to the last question for this particular talk. What is the universal protocol for a PLHIV to start ART? In the past, it is when the CD4 count is below 350, but I heard that regardless of the CD4 count, ART should commence.
Mhm. Yeah, it is true that since 2014, um, the global guidelines is to start ART for everyone newly diagnosed with HIV, regardless of CD4. And this is because we now know that it's not only the imminent clinical benefit that you can get from ART, but it's also that ART can help reduce the amount of virus in your body, which cause unnecessary inflammation, long-term inflammation, and long-term damage to other organs in your body, let's say your liver, your kidney, which can be damage due to this unnecessary inflammation because of the circulation of HIV in your body. And that's why when we start ART to someone, this is not only to prevent you from getting opportunistic infections, but it is also to prevent you from getting this unnecessary long-term consequence or long-term damage to your other organs that will cause you to like age rapidly, for example. That's one thing. And it's not only the evidence that ART is good for everyone, regardless of their immune system, regardless of their CD4 count, but it is also because we are now, like I just mentioned, in the era that ART can be simplified. We have a better regimen of ART, which people can tolerate well, which people can tolerate in long term. That's also another reason why the global guidelines has changed since 2014. However, it is true that in many places, this knowledge or maybe knowledge is not the concern, but the resources that will allow people to really start ART regardless of CD4 may not be available. And at the same time, it's not only from the provider side, but the client side as well. The client may not be aware of these guidelines, this practice of doctors wanting to start ART on everyone diagnosed with HIV. And that in turn is related to your question to Dr. Wong at the beginning of why we're still seeing people coming in late for HIV diagnosis. It's because people just don't know that they should come early. They should test earlier. They should test regularly to identify, to diagnose HIV as early as possible, because we want to start ART immediately for everyone.
Thank you very much, Dr. Nitaya. I know I told you that this is our second to the last question, but in the interest of time, we need to cut the question and answer segment. But anyway, my last question was supposed to be, what's your skincare routine? And you can answer that privately during our chit chat later. But thank you, Dr. Nitaya.
Okay, thank you.
Yes, and on to our last speaker for this afternoon. He is the HIV program coordinator at Raja Community Center in Iloilo, Philippines, to share best practices for the community-based model of offering HIV treatment here in the country. Please welcome Roberto Figuracion.
Good afternoon. I am Roberto Figuracion Jr., the HIV Program Coordinator of the Family Planning Organization of the Philippines Iloilo Chapter. FPOP Iloilo is a non-profit organization whose advocacy and programs caters to the sexual and reproductive health needs of the marginalized and underserved sectors of the society. In 2018, FPOP established the Raja Community Center here in Iloilo City, a high-burden city with a 6.3 HIV prevalence among men who have sex with men. The community-led facility provides a safe space for the key population affected by HIV and AIDS, where they can access prevention, testing, and treatment services. The center is led by staff and volunteers coming from the same community it serves. This model works best in Iloilo because most of the unmet needs of the key population can be answered by providing KP-led services in spaces where they can feel comfortable and accepted. We know the market because we are the market. 5 years ago, we were beset by problems of access to HIV treatment services when it used to be limited to one public facility catering to thousands of PLHIV clients. By putting up a community led facility in the heart of the city, we offer warm reception to clients at the same time as augment the supply to the already rising demand for HIV services, particularly on treatment care and support. At the Raja Community Center, FPOP ensures that the clients receive comprehensive and integrated HIV services. We offer both medical interventions to their clinical needs and non-medical support to their other needs. This ensures that the clients of the center have fewer concerns to worry about and thus help achieve viral suppression and minimize treatment failures of PLHIV clients. Community volunteers are likewise trained to respond to psychosocial needs of the PLHIV it serves by ensuring that these needs are met by services available to the center and services that can be accessed through our partners in the service delivery network. The Raja Community Center has also championed the young key population, with as much as 50% of our PLHIV clients coming from ages 15 to 24. This is significant when you compare it to the data from the rest of the service providers in the city and the region. This sets Raja apart from other treatment facilities because it caters to the hard to reach population. This is true only because most of our KP volunteers are coming from the same subpopulation. Young people gravitate towards their peers, and FPOP have been known to champion the cause of the minors and the adolescents. In 2017, UNICEF and FPOP Iloilo had a demonstration research showing a 408% increase in the rate of testing among adolescents at risk of HIV infection. So how did we do it? We worked hard towards establishing an adolescent-friendly health facility that was eventually recognized and awarded by the Health Ministry. This added capacity to the community-led response contributed to more young people provided with HIV services, from prevention to treatment and care. So how do these young key population respond to these services? They get to invite more young people to come to Raja to avail the same services. Social and sexual network testing have been key in achieving high reactivity rate among our clients receiving HIV testing services. PLHIVs who are enrolled in treatment find it convenient and safe to invite their sexual partners to get tested and treated here. That is the effect when you ensure that there is privacy and confidentiality alongside comfort and convenience. A KP-led community-based center offers warm reception to clients who consider their service providers as family. It helps that sexual health services are integrated with the psychosocial support they are receiving from FPOP's community center in Iloilo. That means a client who needs mental health intervention need not go somewhere else. Or those who seek social protection services can access it from the same center where they get their ARV treatment. Raja strives to be a one-stop shop for their medical needs and their psychosocial needs. A comprehensive and integrated service delivery that is KP-led and community-based can help us achieve our common and shared goals. We may not offer everything, but we strive to give them access to what they need, including access to welfare and livelihood, and even innovations. To provide more prevention options for the community, Raja also offers pre-exposure prophylaxis for HIV that is suited for the key population, including the HIV negative partners of persons living with HIV. They can get these bottles for free, which attracts more from the high-risk groups to access HIV services here at the community center. Being a provider of family planning commodities, FPOP have easily included HRT services to be offered to the transgender community. We are just excited for the coming months when capacity will be added to serve them better. A recent innovation in testing services are the home test kits that are now available at Raja. iScreen is Raja's answer to growing demand for HIV testing services to be more accessible and responsive to the needs of the key population and the community that FPOP Iloilo serves. Why do we pursue all of these innovations? Because we all belong to that same community who understands their needs better. To ensure continuity of uninterrupted services during this community quarantine brought about by the COVID pandemic, FPOP Iloilo worked closely with the Department of Health, the local government units, other treatment hubs, and support groups to serve the key population, including the PLHV clients of Raja. Blended services from online counseling to on-site services cover provisions of prevention commodities, testing services, up to treatment and medical care. Telemedicine and mobile clinics were channels of differentiated care for the already marginalized sector that was badly affected by the pandemic. ARVs were delivered to clients, and prophylactics like PrEP, condoms, and lubricants were front loaded to the community champions for distribution. It is challenging, yes, but with the support and passion from the community volunteers who have preferential care for their brothers and sisters, nothing is impossible. It helps that FPOP has built meaningful partnerships and collaboration with international funders, national government agencies, civil society organizations, and local government and the private sector. As it takes a village to raise a child, it takes a community to care for persons living with HIV. It could be a Filipino thing to be your brother's keeper. And here at Raja, you are family.
Maraming salamat at mahigpit na yakap sa iyo, Roberto. I know that your best practices and experiences would resonate with most HIV care providers in the region. They will certainly take inspiration from your initiatives and successes. And now it's time for us to address some questions from our participants this afternoon. Simulan natin ang tanungan with our very first question, Roberto. How important is having a safe space in continuing access and taking treatment?
Hi, Mela. Thank you very much at Happy Pride from the City of Love, Iloilo. So it is really and very strategic that we ensure clients access HIV services in safe spaces because only within these spaces that they can actually open up and ensure that they will actually receive HIV services from prevention up to treatment. You know, as mentioned earlier, it is really crucial that Appeal HIV maintains the taking of ARV treatment towards ensuring viral suppression. If a service provider or an HIV facility lacks that factor of being a safe space, we will not be able to ensure that they're going to stay, they're going to keep going back and getting their ARV treatment. The same with prevention commodities. Here at Raja, we ensure that they consider Raja Community Center as a safe space where they can get condoms for free and lubricants, as well as right now, we're distributing PrEP. They cannot just barge into their own safe spaces. Here in the Philippines, we have been exploring reaching this key population on places where they converge or they feel comfortable, like their own pickup sites or the hotspots. But you cannot barge in, or even on social media like Grinder. You cannot just simply go inside and then just um, uh, promote these testing services and prevention services or commodities without really immersing with them, making them feel comfortable that you belong with them, that you're not just on top of the pedestal and you're like, um, you're actually just giving them instructions on what to do. It's important that they feel that they and that they want to do it, and they're on a safe space uh, that can ensure privacy and confidentiality of the information. So on all cascade of care that we maintain safe spaces, and we replicate this to many service providers that we have here in the Philippines, public and private service providers.
Yes, thank you so much for reiterating that safe spaces will always entail a no judgment environment, and the goal is just to simply embrace them with arms and open hearts and just simply be concerned with what they are going through from prevention to treatment. And now, Roberto, on to our last question for you. And this is from our participant. Bago natin makita, kamusta dyan? How is it there in Iloilo?
Oh, it's actually modified ECQ right now. So we're actually preparing for ARV delivery tomorrow because we're going to distribute ARV treatment tomorrow to clients in the southern part of Iloilo. It's a little bit challenging, especially that during quarantines like this, we were thinking that maybe there will be no possible sexual encounters among key population, but actually it's different. We're looking at numbers increasing based on anecdotal reports, and we want to make sure that prevention commodities like condoms, lubricants, and even PrEP are available to them. So here at Raja, we're figuring out how we're going to front load those commodities and ensure that they have access to that, especially only one person per family can go out and to ask your dad or your mom to buy your condoms for you. So you really have to find creative ways in delivering the services to Ilonggos, right?
Well, that is good news to hear from you, Roberto. You are doing a great job. And indeed, no pandemic, no COVID 19 can bring our advocacy down. So, on to our last question for you. In the Philippine context, in Iloilo, what if the Ministry of Health is not supporting you equals you? What if DOH is not supporting us in this campaign? We can only advocate you equals you from the root based community.
What's very important with the campaign on you is equal to you is you're direct to the right audience. Of course, the government, through the Department of Health, will always provide services. Like right now, they're getting us the ARV treatment, and we really appreciate it from the community. But the you is equal you message, it's really important that you direct it to the persons living with HIV and those key population who might be at risk of getting infection in the future. So first, among the PLHIVs, like here at Raja, we always talk about you is equal to you. It's not part of the HIV 102 or 103, but as early as their first talk on HIV, we already tell them about that. No? Usually in the past, or maybe like 5 years ago, we start talking about what is HIV, what is AIDS, how do you get it, and what kind of body fluids will you be able to get that transmission. We, I think around 2 or 3 years ago, we started thinking about what if we start about ARV. What if we talk about the solution first and tell people that ARV treatment is working, maybe that would change some attitude and behavior from the key population, and more important, persons living with HIV. If at day one they are familiar already that our ultimate goal is towards viral suppression, they will do everything, including together with us, service providers and community members, to ensure that they'll get to that goal. And what important that we send that message across that once you are undetectable, there's almost no chance of passing the virus to your sexual partner. So it's really important that they know the benefit of you is equal to you and not necessarily push it against our stakeholders. Like as you've mentioned, hypothetically, I mean, if in ministry will not really be supporting it, maybe that's a source for that's an opportunity for advocacy for us coming from the community. We will not stop with that kind of situation. But what's important, communicate that message to the number one, PLHIVs, and to the key population so that they will not be afraid of getting tested solutions to offer. Sometimes you don't want to know that you have a problem or you don't want to know that you have diabetic because you are afraid of taking medicine or you're not sure if there's medicine at all. But if you know that there is solution, you will have you are more precluded and you will be more encouraged to get the testing services. Anyway, it's for free, just like the ARV treatment. So I guess that's how it is important to communicate you is equal to you. Thank you, Mela.
Thank you as well. I want to say this in Ilonggo. Sa liwat madamo gid nga salamat kag maayong hapon sa inyo tanan. Did I say it correct?
Yeah, Ilongga, guapa.
Yes. Happy Pride to you and thanks to you, Roberto. Have a great afternoon to everyone there in Iloilo and friends who are watching us right now. That ends our third session for You Matter Symposium. We will be back for our session 4, and that is all about you leveraging on HIV self-testing. And that will be after our 30-minute break. To all our participants who have asked their questions, thank you very much. We hope you enjoyed this session, and we would like to thank our sponsors, those who made this event possible. Thank you, Viv Healthcare, Merck Sharp and Domi, Gilead Sciences, and the Swiss Agency for Development and Cooperation, or SDC. Thank you, because without you, this virtual symposium won't be happening today. I'll be seeing you again at exactly 3 p.m. later. So now, let's take our 30-minute break and relax and enjoy what we've learned so far from our speakers. See you